everybody. Welcome to the 2016 series of webinars for the State Unit on Aging. We are partway through the year. Where is it going so fast? We're really excited today. This one is geared for the ADRC community, and we have Donna Delicat and Cynthia Hilton from the Sheba folks who are going to talk with us about Medicare. But before I let them start talking, I just want to remind you guys that we are recording the webinar today, and it should be posted by next week. Want to remind you guys that we keep you all muted so that we can keep you muted so that there is no feedback and no sound issues. So you'll need to text chat your questions if you have any. And I've chatted with Donna, and she would like to just go through her material, and she will pause every so often for questions. So type your questions in as you think of them, but we may not get to them right away, but she has put some little pauses in, so we'll answer them, and I'll be helping her do that. We also have in the room Ryan Kibbe, who's my teammate from SUA.
Hi, welcome everyone.
So he's our connection at SUA with the Sheba folks and works on those grants, so he's going to be here to help ask and answer questions also. If you're a group site, remember that we really like to have you let us know who else is there so that we can keep track of folks who pay attention to the webinars. We did send out materials yesterday afternoon, sometime yesterday. So hopefully everybody has the materials. And I want you to make sure you watch after the webinar. Within the first hour after the webinar, I will be sending you an email with a survey link to a Survey Monkey. It's just a quick little 6-question evaluation to let us know how we did. So at this time, I would love to introduce Donna and just let her take over.
Well, hello everybody, and thank you for attending today. My name is Donna Delicat. I am a field officer with the Sheba program. That's the Senior Health Insurance Benefit Assistance. And with me today remotely is Cynthia Hilton. And Cynthia, if you can just introduce yourself too so they know your voice.
Hi, it's me, Cynthia.
And we're going to run through some of the basics today of just the out-of-pocket costs associated with Medicare. We'll do a real quick review of the Medicare program, and then we're going to dive a little bit deeper into some of the subsidy programs and the financial assistance programs that are available for Medicare beneficiaries who meet certain eligibility criteria. So in your handout or in the screen, we're going to go to the next slide. And it looks like an awful lot that we're going to cover in this hour and a half, depending upon questions. But maybe we won't get too deep, but we'll at least whet your appetite for finding out more information. If you have any questions that aren't answered or any client situations that you want to run by us later, certainly feel free to email either Cynthia or me. We're in the global Outlook of Donna Delicat and Cynthia Hilton.
And Hilton is spelled with a Y, H-Y-L-D-O-N.
Is your email information at the end of the PowerPoint, Donna?
I don't believe it is. Let's see, what did we do? We did not include our contact information, but we certainly can add that when we post to the State Unit on Aging training website.
Great.
So that'll be helpful. All right. So let's talk a little bit about Medicare. First of all, for most folks, Medicare is going to be available to them at age 65, or if they have applied for and received Social Security disability insurance payments for 24 months, and on the 25th month, they become eligible for that Medicare benefit. A lot of times folks are pretty confused because they hear you have to enroll in Medicare at age 65. The most common question that I get in the Medicare 101 class is that I teach is, but I'm actively working, or my husband is actively working, and we are already covered with insurance through that active work employment. If someone is covered through an employer group health plan through active work, that is the only criteria that Medicare allows folks to delay enrolling in Medicare without incurring any kind of a lifetime penalty. It doesn't even have to be a large employer group health plan. However, you'll see in the smaller bullet, the sub-bullet, if the employer is a small employer, which constitutes someone who, or a business that has less than 20 employees, that employee group health plan still protects that person from penalty, but it does not pay primary. It's a protection for small businesses to have that small business group health coverage as secondary to Medicare. So for a lot of folks who may think that they are able to delay enrolling in Medicare, that's absolutely correct. They're not going to incur any kind of a penalty, but it also beckons the question, is your employer have more than 20 employees in that group health plan, because that's going to determine the coordination of benefits between that employer plan and the Medicare group benefits. Part A is the hospital insurance, and you'll notice on the slide the inpatient is italicized and underlined, because that is a pretty distinct status when you are in the hospital. A lot of times folks go into the hospital through the emergency room, and until they are formally admitted as an inpatient, Part A is not covering their stay. Once they are formally admitted as an inpatient, now Part A is covering their stay, but it's only going to cover the facility, the room, the board, general nursing and supplies and medications while they're an inpatient in the hospital. All of the other services they receive while they're in the hospital, physicians, MRIs, surgeries, things like that, that is going to be covered under the Part B part of Medicare, which is the medical coverage. And so folks who are in the hospital, maybe just in the emergency room, that's covered under B. Or if they don't get admitted as an inpatient and they are observed for a while and they're still in the hospital bed just like they were an inpatient, that's still going to be covered under their medical Part B. So it can be very confusing for some of our clients when they get those bills. Why was it covered under B and not A, or why the reverse? So oftentimes we're encouraging folks to ask what their status is when they're in the hospital. Now, some of the rules for Medicare have changed just recently. Medicare was getting a lot of complaints because this status was so easily confused. Now hospitals are required to tell folks what their status is on a daily basis. So here's a classic example. I have chest pains, and I don't know what those chest pains are all about, so I go to the emergency room, and the emergency room doesn't know either right away, so they're going to admit or put me in a bed, hospital bed, and observe me for a while until they run tests and they determine, is it something serious that requires me to be in the hospital, or is it something that they can just prescribe an antacid and send me home? So once they run those tests and I have been observed for a while, now once I have a diagnosis, if it's a blockage or I need some kind of intervention that is only available in the hospital, my status will change to inpatient, and I'll get the services under my Part A hospital coverage and the facility under my Part A hospital coverage, and the Part B medical, all the surgeries and all the other tests and things will be covered under that. So you probably have some questions on that, and we can clarify that as we go along. and I'll stop in just a few minutes and we'll look at some of the questions. So moving on, Part C is now called Medicare Advantage, but they use that same naming convention. They wanted to stay with the A, B, C, D. So Medicare Advantage is commonly called the Part C, or it used to be called Medicare Plus Choice. And these are private insurance companies that have contracted with Medicare to provide all of the same benefits and sometimes even more benefits to folks who want to sign up for that particular company's package. And it is a bundled package, so it combines hospital, medical, and most often drug all under one umbrella, and then that particular company is responsible for managing all of those services and benefits for their members. Medicare says they will not process any claims if someone is enrolled in a Medicare Advantage plan. That Medicare Advantage company is responsible for handling all the claims, all the benefits, all the grievances and appeals, if they have any denial of services, all of the contracts with their durable medical equipment providers, all of the prior authorizations. So really and truly, Medicare steps back. They're still the foundation of coverage, and the plans still have to contract with them. But Medicare is not managing that person's benefits. It's the plan that they have chosen to enroll in, like a Regence Blue Cross or a Providence or a Health Net or some other very common name company that we all deal with. They have products in every market, so a lot of times it's can be confusing unless we narrow it down and find out specifically, yes, they are in a Medicare Advantage plan, and the plan that they have enrolled in is the Bluebird plan, and it has these benefits, and the company sends out a document called the Evidence of Coverage, and that becomes their policy, and they can look and see in their policy which services and or items are covered and what their out-of-pocket cost might be for that. So that's just a basic overview of the Medicare Advantage product. And then the last thing that Medicare offers now, as of 2006, is prescription drug coverage. And staying with that same naming convention, Part D refers to the portion of coverage that covers the prescriptions, whether it is a standalone prescription drug plan or whether it's part of that bundled package that was included with the Medicare Advantage product. Because as I said, you can have health only or you can have health and drug, so that drug component is also considered Part D, or prescription drug coverage, that satisfies that prescription drug benefit that Medicare offers. So just to show this in picture form, and there are some associated costs with all of these programs. Original Medicare is A and B. So to reiterate what we covered just briefly, A covers room and board, general nursing and supplies. It also has a home health care component, so if you were hospitalized and discharged and you need some home health care from skilled services, either you have wound that needs to be dressed or you have some physical therapy following maybe a joint replacement or any of the other factors associated with that hospital stay, you can receive home health care, and you can even go to a skilled rehab facility and received skilled nursing services. So a lot of times we have folks that have fallen and maybe they have busted a hip or something and they get the hip replaced, then they need to go to skilled rehab so they can get that rehab, especially if they don't have a natural caregiver at home, but especially if they have a natural caregiver at home, because sometimes rehab can be really stressful on natural caregivers. And If somebody needs to have that skilled nursing and they chose to go home, they can always talk to their physician, and that physician can recommend and order that they go to skilled rehab if they do so within 30 days of discharge. I didn't mention hospice. Hospice is also covered solely under Part A, regardless of whether or not you are in a Medicare Advantage plan. So if you're in a Medicare Advantage plan and you are diagnosed with a terminal illness and you want to go on hospice, it's always going to be covered under your Medicare Part A benefits, and you can choose any hospice, not necessarily the hospice that is associated with the Medicare Advantage plan that you are enrolled in. Part B covers all of the other things, including the services you receive in addition to your hospital stay, like the surgeries and the tests and the durable medical equipment and emergency rooms and ambulance rides and things like that. All of that is covered under your B medical benefits, but there's a deductible associated with B, and this year it's $166, and then after that deductible is met, Medicare typically covers 80% of medically necessary services. Now, certainly a tummy tuck is not going to be covered by Medicare, so it does have to follow that medically necessary criteria. When you are looking at adding prescription drug coverage, you don't have to be in both parts A and B in order to add drug coverage. You have to be in one or the other, either A or B, and then you can add drug coverage. You just have to be enrolled in the Medicare program in some way, and then you are allowed to sign up for prescription drug coverage. And we do have a lot of folks that have other prescription drug coverage, like maybe veterans. They have drug coverage through their VA benefits, and so it's an option for them. But folks that don't have any other drug coverage need to consider the penalty, because even though it's an option, if you decide today not to enroll in the Medicare drug program, but then maybe a year or two down the road or several years down the road, you need to enroll in it because now you have medication needs, there is going to be a late enrollment penalty assessed for that drug coverage. And it works out to be about $4 added to each month's premium for every 12 months that you are not covered by a Part D plan or something that is as good as Medicare's Part D coverage. So good to have a conversation with folks. I just had a gentleman today on the phone. He was in a Regions Med Advantage plan that had no drug coverage, and he was totally unaware that he didn't have prescription drug coverage. And he was paying out of pocket and thinking, boy, my insurance sure isn't covering very much. And when I looked him up and I said, you know, you don't have any prescription drug coverage. If he wants to jump in the fall for next year, he's going to have to pay a penalty for all those months that he was in a plan without coverage, and because he doesn't have any additional coverage. So, and that was just, he didn't know. He didn't have any idea. He did not get good information from a reputable source. And so that's why we like folks to come to Shiva. Our counselors are highly informed about these things, and they are very good at finding out what folks' best interests might be and getting them into the programs that they need. Cynthia, did you have anything you wanted to add to any of that?
The only thing you missed was Part A does also have a deductible, and it is not an annual deductible. It is a benefit period deductible, and it's about $1,288, and it's based on time periods. Benefit periods. So a person could conceivably have more than one Part A inpatient deductible in a year if say they were admitted as an inpatient into the hospital in January and then discharged and after a few days. And then maybe in April they had either the same problem or another problem and were admitted again, and they would be charged that $12.88 again because more than 60 days had passed between their discharge and their next readmittance. So that's a considerable sum of money for lots of people. So it's a consideration for, that's part of their cost share for Medicare for their hospital coverage.
Good point. Yeah, thank you for reminding me about that. The deductible could actually occur mathematically 5 times in any given year. If someone was an inpatient for 2 days and then discharged for 60 days and then they came back in after 60 days, they would have that $12.88 again. And then if they were in a couple of days and discharged and out for 60 days. So you see how it could be very expensive. And you can see on the slide presentation, there are a considerable amount of out-of-pocket costs associated with the Medicare system. So a lot of times our folks on Medicare will want to add additional insurance policies to either reduce that risk of financial out-of-pocket cost or to eliminate as much of it as possible if they can. So good point. Thank you. So we're going to talk a little bit about how we can help with some of those costs. Oh, we do have a question. Well, I was going to stop in two more slides, and we'll take some questions. One of the policies that can be added to offset those out-of-pocket costs for A and B is called a Medigap. Legally, the term is Medicare supplement, but most often it's referred to as Medigap because there is a gap between what Medicare says is the approved amount and what the 80% that Medicare pays. So there's a 20% difference in there, and that's what Medigaps cover. And there are 10 different levels of coverage depending upon how much somebody thinks they need. Lots of people are very risk averse and they want as much coverage as possible. That would be a Plan F, as in Frank, or they might have something with less comprehensive coverage. But either way, it works pretty neat that Medicare processes a claim and automatically crosses over to the secondary insurance, and then the secondary insurance really does not quibble at all. It looks at what Medicare has processed and say, okay, here's the policy that this person has. We're going to pay according to policy benefits, and they just pay the difference, whatever that policy benefit is. So it's definitely a popular way for folks to add coverage to mitigate some of that financial out-of-pocket risk. And it's a more easily budgeted amount because it's a monthly premium. It's much easier for folks to budget a monthly premium than it is for folks to come up with thousands of dollars out of pocket at a moment's notice when they've had a medical emergency. So the last line on the slide says it does not cover prescriptions. When the Part D program became available in 2006, all the policies that used to cover prescription drugs in the Medigap marketplace stopped being sold. And that drug coverage was actually considered not as good as the Part D program. We still have a very few policies out there, maybe less than 100 in Oregon, that still have held on to their older policies that have some drug coverage, but it's not considered creditable. It's not as good or better than what Medicare offers, so if they were to switch now to a Part D plan, they would incur a late enrollment penalty. So that can be spendy for some folks. Okay. So with Medicare Advantage, sometimes folks choose that because that's going to be a lower out-of-pocket cost as well. Medicare Advantage, as I stated earlier, covers all of the A and B and most often D benefits, and it is a pay-as-you-go kind of system. But instead of not having a maximum, it does have a maximum out-of-pocket. So what happens is somebody enrolls in Medicare, they're in A and B, and they want to go with their Medicare Advantage company. Maybe they've been a Kaiser member their whole working life, and they want to stay with Kaiser after they retire and they go on Medicare. So Kaiser is contracted with Medicare, and they can keep their same providers, but there's a premium to belong to the Kaiser network, and then each time you go in to receive services, a doctor's appointment or a lab test or something, then you're going to have a copay associated with that service. And if your copays reach a certain dollar amount, I believe with Kaiser, the Medicare Advantage basic plan is pretty high. I think it's $4,500. But then your copays stop once you reach that amount of out-of-pocket costs. It does not apply to any of the prescription out-of-pocket costs, just your medical out-of-pocket costs. But the thing about Medicare Advantage plans is not only do they provide you with all the Medicare benefits, but a lot of times they provide additional benefits that Medicare doesn't cover. For example, Medicare does not cover getting your eyes checked on a regular basis unless you have diabetes. They'll check for health of the eye, cataracts, glaucoma, macular degeneration, retina issues. But as far as just your regular vision and getting your glasses updated, Medicare does not cover that, but Medicare Advantage plans often do, because their philosophy, I think, is we better update this person's glasses, otherwise they might trip and fall and break a hip, and then it's going to cost us more money. So vision is one. Dental is a very big need. We get probably our second most frequent call is, I need dental services, I have an oral health issue, I need to have my knee surgeried, my surgeon won't schedule my knee surgery till I take care of my oral health, and Medicare doesn't cover any oral health benefits. So Medicare, again, Medicare Advantage plans will oftentimes, if they're not included in the basic package, they'll offer an additional rider that allows folks to add some preventive or restorative dental benefits to their package. And then the last thing that we usually highlight are the fitness benefits. Many of the Medicare Advantage plans have silver sneakers or silver and fit. Again, it's to encourage folks to stay as healthy as possible. The Medicare Advantage plans that offer these benefits and keep their members healthy are viewed by Medicare as being very good performers. And so they get compensated a little bit better when they're keeping their members healthier and not having as many claims. And so the Medicare Advantage plans and the prescription drug plans are rated by Medicare. They have a star system. 5-star is considered the best that you can have. Anything less than 3 is considered below average. So 3 to 5, 3 is average, 4 is above average, 5 is the best you can get, and only Kaiser in 2016 is a 5-star plan. In 2015, it was Kaiser and Providence. So every year, Medicare reevaluates the plan complaints that have been received by members and then evaluates on a pretty broad criteria. It's about 35 points, what that company's performance has been and how well they're doing with keeping their members healthy. Cynthia, do you have anything on that I missed?
Well, not only just healthy, but also providing the right kind of customer service. You know, how quick do they respond to appeals or resolution for issues or problems. So clients need to really be encouraged to understand that they have avenues they can pursue either through the Sheba program or through calling 800 Medicare, where they can say, my plan is not helping me resolve this issue. We have a disagreement about something, and there's oftentimes they don't return phone calls maybe when they say they will, and those are reportable incidents, and that really contributes to plans are heavily motivated to provide better service when their customers use the system that is designed to help them make sure their plan is helping them resolve problems.
Very good. And that's absolutely correct. So we'll do one more slide and then we'll ask some questions. I do have one that says, how much money does Medicare pay the Medicare Advantage plans for each patient in order to manage their health insurance? We have heard many years ago now, at that time it was around $800 per person per month that the Medicare Advantage plans received to manage the Medicare benefits for that member. I don't know if that's still accurate. It's very difficult to find that information. We got that from our regional training officer up in Seattle, who is no longer with us. But I imagine it's probably somewhere in that neighborhood. Now, there have been some cuts to Medicare Advantage plans, and when we hear a lot in the media, Medicare benefits are being cut, that's typically what they're referring to. They're not referring to the original Medicare program. They're referring to the Medicare Advantage reimbursement rate. And the last number that I heard, and Cynthia, you can correct me if you've heard something different, is they are reimbursed at 114% of the going Medicare original program rate.
That's
about what you heard too.
Yeah, that's the latest. But we will see some ongoing reductions in the future. And so we will see Medicare Advantage plans upping their copays and or reducing any extras.
Right. And the Affordable Care Act did touch the Medicare program in this one area. The medical loss ratio is 85%. So what that means is that the Medicare Advantage companies must spend 85% of the income that they receive from Medicare and co-pays and premiums on benefits. They're allowed to keep 15% for profit, overhead, marketing, all of that stuff. But their medical loss ratio is pretty high, so that they're going to give most of that funding to the benefits and or the members in saving them some money, either lowering that maximum out-of-pocket amount or adding additional benefits like the vision, dental, and fitness club. But even with all of those cost reductions, some people still cannot afford to pay a premium for their Medicare Advantage plan and the co-pays each time they go to a physician or a clinician, or maybe they're in a very expensive medication regimen and they have high co-pays for their medications. So we have some assistance programs that work with Medicare, and that's what we're going to touch on next.
So that was the only question we had. So if you have other questions before we switch gears and go in a different direction here, please go ahead and type them in. I think that was the only one. And remember, we don't, the hands up doesn't work. We're just looking for a text chat or questions. So I'm not seeing anything, Donna, so I think we're ready to
keep going.
Move ahead, yeah. Double check, I don't see anything more. Yep.
Okay, great.
Alrighty. So remember, just whenever you think of a question, go ahead and put it in there, and then we'll stop again at the end of this section to answer whatever questions you have.
Okay, so the next part we're going to talk about the low-income subsidy, or LIS. And the Sheba folks deal with LIS quite a bit. We are always looking to save our clients some money. And if someone is eligible for the subsidy, we want to get them enrolled. We have a lot of people out there who are eligible but not enrolled, and so part of our MIPA funding that we get is to do outreach to those communities where we have higher populations of folks that may be eligible but are not currently receiving that benefit. So this is a federal program, and it does have means testing, so income and resources do apply, but there have been some changes in recently, so we're going to go through some of those changes. Right now, what we typically do is we go through a website called Benefits Checkup, but that application is sent to the Social Security Administration to determine eligibility. Social Security is in partnership with the Internal Revenue Service and with other forms of collecting information on folks' income and assets. And so Social Security is the one that gets to process these applications and determine whether or not someone is eligible for these benefits. The fastest way to get your application determined is online. Paper applications can take 3 to 4 times longer than an online application. An online application typically is processed within 30 days. The date of request is very important because if you request or apply even at the end of the month and then 3 weeks later you find out you received that subsidy, your benefit starts at the first of the month that you applied. So if I apply today on the 13th and I find out the first week of August that my subsidy application has been approved, my benefits actually started July 1. And a lot of times we can have folks go back to their pharmacies, give them the right processing codes, and that pharmacy can rerun those prescriptions that were purchased, and then they can either get a refund or apply that credit to their next purchase. So that's a really fast way of getting it. The other way that we would like folks to try and get the applications processed is through the Oregon Medicare Savings Connect phone number. They are funded by our MIPA grant specifically to process limited income subsidy applications. It takes about 10 minutes. The gal who answers the phone is Diana Barnard, and she's absolutely fabulous, and she'll get someone hooked up if they're eligible immediately. And we have some job aids and handouts associated with Oregon Medicare Savings Connect at the end, and with their phone number and printable that you can use in your daily work. So let's just review real quickly about the standard benefit for the prescription drug program. And the thing I like to start off with is, as employees, most of us have prescription drug coverage, and we have a deductible, and we pay out of pocket until we meet that deductible. And then we have a benefit, and maybe our benefit is we have a prescription that costs us a $15 copay. And it's pretty straightforward for the rest of the year. We don't have any ups or downs. Typically, it's usually copay. Occasionally, for a higher medication, it might be a co-insurance, which is a percentage. But with the Medicare program, they didn't make it quite as simple as that. They ended up coming up with a 4-stage benefit program. And the 4 stages can be very confusing to our clients, and so that's why we're going to run through this just briefly. The stage 1, if the plan has a deductible, is the deductible stage, and this year the maximum deductible is $360. So remember, this is the standard benefit. Lots of plans have enhanced benefits, and maybe they don't have a deductible at all, or maybe their deductible is only $150. That would be an enhancement. The standard benefit says the deductible cannot exceed $360. So once that is satisfied, you leave stage 1 and you go into stage 2, which is the initial benefit period. And during that initial benefit period, on average, the insurance plan is going to pick up about 75% of the cost of the prescription, and there is a 25% co-insurance. Now, for some plans, they have a $5 copay, or maybe if you get it through mail order, it's a zero cost. So when I say on average, it just means if you were to take an aggregate of all of the prescriptions available and the costs associated with it, it's going to be on average 75-25. 75% covered by the plan, 25% out of pocket. So on that color slide, you see there's a green bar at the top. And that green bar actually does, that color coding actually has some meaning because it represents the 3 boxes below it. Yellow and blue makes green. So once all of those boxes equals $3,310 in contracted total value of prescriptions purchased, then that person is going to exit stage 2 and they're going to be in stage 3, which is called the coverage gap, or infamously the donut hole. And in the donut hole, the cost shares change pretty dramatically. In the beginning, this used to be all yellow. It was 100% out of pocket. And folks were not happy with that because before they had the insurance, they were paying 100% out of pocket. And now they're paying a premium for insurance, and they're still paying 100% out of pocket. So this is one of the other areas where the Affordable Care Act did touch Medicare. And what it did is it provided for the donut hole to close. And it started in 2010, and it'll finish in 2020. So we're a little bit over halfway there. And right now, the out-of-pocket cost for a brand name is 45%, and the generic is 58%. It's a combination of the patient assistance program manufacturers kicking in 50%, and then the plans stepping up and paying a little bit more. But as we go through time, next year the brand names will be 40% and the generics will be a little lower. By 2020, it's going to be 25%, all the way from stage 2 to stage 4. So that's going to be a big benefit for folks who have a high cost medication regimen and that they need to have that financial protection. Once you have spent out of your pocket $4,850, and you see at the bottom there in orange, TROOP. That stands for True Out of Pocket. And right now it's not even true out of pocket anymore because the color coding applies as well. Yellow plus pink equals orange. So that 50% manufacturer's discount is actually getting credited to that person's out-of-pocket costs, even though it's really not coming out of their own pocket. It's a discount that the manufacturers are supplying at the point of sale. So, but getting back to that orange bar at the bottom, the $4,850, if someone does have a very expensive medication need, maybe they're on a high dose of insulin, maybe they have some medications for multiple sclerosis, we see that oftentimes, or even ALS. Folks can be in and out of all these stages in 1 month. Maybe their one injection is $6,000 a month. So that out-of-pocket cost is exceeded, and now they're in stage 4, and that's called catastrophic coverage. Now the program picks up 95% of the cost of medications, and the out-of-pocket cost is limited to 5%, or the dollar amounts that you see there, $295 and $740. So depending upon what someone's medication needs might be, they may never get out of stage 1 deductible. Maybe they're on all generics, and their generics are not going to exceed that deductible. Then again, maybe somebody has that $6,000 a month injection, and they're going to be through all 4 stages by February. So I've had both happen on many occasions, and we're always looking to help folks that have those high out-of-pocket costs reduce that financial burden, and that's what we're going to talk about next, is the subsidy that's available. So on this slide, on yours, I apologize, I think I neglected to change the top that said 2015, but I've corrected it. It says it should be 2016 in your handouts. This is the federal subsidy program and how folks can qualify based on their monthly income or their annual income. And the reason why level 4 is circled is because it's the only level where resources will actually apply anymore. The first levels, the 100% FPL and the 135% FPL, are going to be automatically deemed eligible because at that level of income, they're also eligible for state benefits. And anytime you're eligible for state benefits, the new rules under MSP, Medicare Savings Program, is that assets do not count. So federally, they still count, but the feds have said, gee, Oregon isn't going to count assets anymore for folks who are eligible for Medicare Savings Program, so we're going to allow those folks to get that federal subsidy as well without us counting their resources either. So that is a big change that just happened this year, January 1. And so the only time someone would really need to be aware of their resources would be if they're above the 135% federal poverty level, and now they're looking at maybe that level 4 subsidy coverage, and then those assets are going to take effect. Cynthia, did you have anything you wanted to add that I may have missed?
Well, just to kind of clarify it a little bit more, the Medicare Savings Program pays the Part B premium, and it can sometimes at the higher benefit level will also cover the co-insurances that go with original Medicare. So that level 4 is for folks who are not going to qualify for that, but they still need help and can qualify for the subsidy that will help them with their drug costs.
Right. This would be for folks who aren't eligible for any state other benefits, just needing the financial assistance program with prescription drugs. That's right. Correct. Okay. So that's a good segue into the next slide, which is the Medicare Savings Program. And it is state-run. It's federally matched. The program, we refer to it as Medicare Savings Program, but a lot of times the state offices refer to it as the QMB, or Qualified Medicare Beneficiary Program, and there are 3 levels of coverage under that program. The basic is the highest level of financial assistance, and it was what Cynthia just said. It covers the Part B premium and the deductibles and the 20% out-of-pocket cost share associated with those medical expenses. If someone is not meeting that eligibility, they're not dealt out of the club, the SMB and the SMF is a higher income allowance, but it still pays the Part B premium. It just isn't going to pay the deductibles or the 20%. So the big thing to remember here is up until the end of 2015, we were looking at assets and resources, and starting in January 1, 2016, that no longer applies. Now, we did just get an email today that there is some special circumstances for folks who might have access to a retirement or a pension if they are waiting to take that in a lump sum, and that's the only way that they can get it. It's not counted. but if they are allowed to take it in monthly increments, they are required to pursue that income, and that may put them over the mark. So there's some little nuances that we're hearing about this program, but I think that's going to be less common than the ones that don't have to have their resources counted at all. So let's look at the chart, and this is pretty straightforward. There are the three silos, the QMB basic, the SMB, which is the middle, and then the SMF, or qualifying individual, on the right. And you'll see the varying percentages of the federal poverty level, and whether or not they're a single or a couple, and then it goes on up depending upon household size or family size. So the SHIBA program is not in the business of determining eligibility. We always refer to the local senior services offices or the APD offices and say, please, determine eligibility for this individual, because they are the specialists in this area. But we want to know what the parameters are so that we can make appropriate referrals to their local senior services offices in order to get that determination made by the eligibility specialists. Cynthia, did you have anything you wanted to add before I go on?
Nope.
Okay. All right. So again, here's Oregon Medicare Savings Connect and the phone number. And it has regular office hours, but also a 24-hour voicemail system. So folks can call and leave their name and phone number, and they will get a return call. The program is funded through our MIPA grant funds, and it's been running now for, Ryan, 2-3 years?
This current one, yes.
Okay. So it's a well-oiled machine at this point, and we're really glad to have this opportunity to have that for our partner network as well as our SHIBA network and for our clients, because this is available for clients to call mainly, but it's also available for our partner network to call. So let's look at some more information about that. If someone is calling for applying for the limited income subsidy program, and Diana determines, well, gee, you might actually be eligible for the Medicare Savings Program, she can take an application starting point and then forward that to the local Aging and People with Disabilities office and get them determined for that additional Medicare Savings Program benefit. So it's a very handy one-stop shop for our clients and for our networks to be able to get somebody started in that process without them having to even leave their home. And once that electronic application is forwarded to the local APD office, then they'll contact that applicant and get additional information to substantiate their resources, or excuse me, their income and their eligibility, and then they'll get processed that way. So it's a really nice way to get folks in the door without having to have a whole lot of angst on the part of the person. Go on to the next one. So we do have a number of outreach and education events available, and Ryan Francario is the other person at the Oregon Medicare Savings Connect office, and she does a lot of the outreach and education. We've got the job aids and the handouts available at the end of this presentation, and they've got color, glossy, printed half sheets that she can send to you if you want to have those on a table for health fairs or any kind of outreach that you're going to be conducting as well. So I added this other slide for limited income newly eligible transition. That's what the NET stands for. And when somebody on Medicare is eligible for that subsidy program, I'll use that same example, I apply today on the 13th of July, and I don't find out until the first or second week of August that I am eligible for that subsidy. My benefit actually started way back July 1 because I applied in July. So this LINET, or Limited Income Net program, allows folks who have received notice that they're eligible for the subsidy until they are in a Medicare prescription drug plan to get that subsidy benefit. And it bridges the coverage between the time you are eligible until for the program and until you're in a plan and getting your subsidy delivered to you through your prescription drug company. So the LINET program is pretty nifty. It was started at the same time they started the prescription drug program because they knew folks were going to be needing to have assistance until they got their insurance. And so when somebody gets notice, maybe the second week of the month, that they are now eligible, LINET can give them that same benefit immediately. And for the Sheba folks that are on the line, you're probably more familiar with this, but a lot of folks are not familiar, especially some of the pharmacies are not familiar with this. And so there is a lot of, there's some codes that we can call the pharmacy with. They're called BIN and PCN codes, and we give that information to the pharmacy, and they will accept our, as a Sheba counselor with a unique ID through the CMS system, they will accept our word for it for a certain amount of time. Within 21 days, we have to prove that that person really is eligible for that program. And that could be in a number of different ways. It could be a letter from Social Security that says that they were awarded that subsidy. It could be a letter from the local senior services office that says they're eligible for the QMB program or the SMB or SMF. So as long as we have something that says, yes, they are eligible, that's considered best available evidence. And best available evidence needs to be faxed to the LINET program within 21 days. So they'll take our word for it for a certain amount of time, but we do have to follow it up with some legitimate documentation that's going to let that program know that they are eligible for those benefits. If not, and if they are not eligible, they are going to have to repay that subsidy benefit. So LINET is a great program, and it really helps our folks get the subsidy immediately and reduce their out-of-pocket costs until their prescription drug plan is implemented. Anything else, Cynthia, you want to add?
Well, I think that your example is really excellent because, an application done the 13th of July, notification sometime in August that you actually qualify, and it will be September 1st at the earliest that a person might actually be enrolled in a Part D plan. And that's under the best of circumstances when they are actually taking an action to get enrolled as opposed to waiting until an auto-enrollment happens, which can add a few more months onto the time wait. So this is a way that, and generally people really do need that assistance as soon as possible. And so this really changes up that whole wait time. So they're not waiting as late as September 1st when they said in July, I need help.
Right, exactly right. So that is a really good tool for folks, especially if they're going through either an ADRC office or an APD office. We want them to get those benefits as quickly as possible. If you need more information about LINET, it is available on the internet, or you can call either Cynthia or me, and we will be glad to point you in the right direction for that. There's, in fact, I could even include the LINET brochure in the handouts. Let's do that.
Right.
I should have done that.
Okay.
Another program that is often missed for folks who may not be eligible for subsidy, and they may not have known that they needed to get into a prescription drug plan, and maybe it's July and they have to fill some prescriptions until they can get into a plan in the fall, which isn't going to take effect until January. So what do people do? Well, there is this really neat program called the Oregon Prescription Drug Program, and it's a discount program. It's a bulk prescription drug purchase that Oregon and Washington states have gone in together to help reduce the cost of some of these prescriptions to folks that don't have insurance. So it's not a replacement for insurance, but it does have some very significant discounts. And what I have found sometimes for my clients that are on a Medicare prescription drug plan, maybe they are bumping up against that donut hole, and we need to take some of those drugs off their list to keep them from falling into that donut hole. Well, I'll go look on the OPDP website, and you can actually go and price out prescriptions right there, and if they can get them at the same price or less than what they're paying on their insurance card, it keeps them out of the donut hole. So, or somebody who doesn't have drug coverage at all, and now they have a diagnosis and they need to buy something, this is going to give them a really significant discount, mostly on their generics, but also a little bit on their brand names. So it's not a big of a discount on the brand names, and a lot of times those are still going to be unaffordable, but certainly the generics are definitely worth looking into on just about everybody's prescription drug list. But it isn't a substitute for insurance. It does not work in combination with insurance. It's an either-or situation. So if you have an insurance card, you're either going to use your discount card or you're going to use your insurance card. You don't get to use both for one purchase. But like I said, sometimes we can move drugs off of their insurance card program, and they can buy it with their discount card, and then they're going to get all their more expensive and or better covered drugs under their prescription drug plan. Very easy application. It's on opdp.org. You do have to put in the www on this particular one. The website did not get optimized to just put in OPDP. And again, it takes less than 5 minutes. Name, address, birth date, telephone number, and I think that's it. And it's free to anybody and everyone. So the more people who sign up, the better the discounts. And tell your friends and family. It doesn't matter if you're employed or insured or healthy or unhealthy. They take everybody, and it's a great discount program. And that was a hard-fought battle to get that a part of our options.
Yeah, it was actually Bill Morissette, I think, was in the state legislature, was a huge mover and shaker and making OPDP exist and to connect, be used by even folks that were on Medicare. And it's not a promotion. You know, there's so many discount cards out there that are just kind of they're just trying to act like they've got something really good going, but they've got something to sell. They have an agenda. And this is not agenda-backed, other than it's just an effort to provide Oregonians with the cheapest cost through this bulk buying group.
Yes, and I forgot to mention it covers any prescription, even prescribed vitamins. So a lot of times we have folks that are on situations where they need high doses of D3 or they need high doses of B12, and their physicians have subscribed or prescribed those for them. The OPDP program covers any prescribed item, whether it's a pharmaceutical or a vitamin. So that's a good thing too. So a couple other assistance programs I just want to make folks aware of. NeedyMeds.org, you may already be aware of. It is a nonprofit organization that consolidates a lot of the patient assistance programs in one place. So if you go to NeedyMeds.org and you're looking for coverage for a very expensive medication, and they'll tell you, you put in the medication name, and then if you click on the little pill symbol, it'll tell you whether or not there are manufacturers or other patient assistance programs that will provide financial assistance for that specific medication. And oftentimes it'll say whether or not people who are on Medicare Part D are eligible, or what their criteria is, if they have to meet a certain level of income with federal poverty level. They've got a federal poverty level income calculator right on the website. It's very handy, and they have a chronic disease tab where you can look up maybe somebody has a chronic illness, and that particular foundation is going to have a way to assist them with the copays. I know the Multiple Sclerosis Foundation does help people with some of their very expensive medications. Those medications can, like I said, run $6,000 an injection per month. It's very expensive. So Needy Meds is a really necessary, and I'm thankful to have it, resource, so we're not having to look all over the place. They take all the information. They have some great webinars on that as well to help you understand how to use their website better, and then it's just going to forward or provide whoever's looking for the information, the different manufacturers in the order of most assistance first, and then further on down the road, if there's multiple programs, there might be a copay assistance program rather than a patient assistance program. Or maybe there's going to be a discount coupon or something. So great resource for folks who are looking to shave off a little bit of cost. And the criteria is typically higher than the limited income subsidy. So limited income subsidy stops at 150% of the federal poverty level. Some of the patient assistance programs go up to as high as 400% of the federal poverty level. So it can really have an effect for people who are dealt out of the other subsidies but are eligible based on the manufacturer's programs. The last one that I want to talk to you about is called Serum, and it's relatively new. It's based out of San Francisco, and their whole business plan is to collect all the pharmaceuticals that are left behind in nursing facilities, assisted living facilities, places where people have either passed or maybe they have stopped taking that medication, but they've been in a controlled environment. They're going to collect those medications and redistribute to people in need. So it's considered a charitable pharmacy. They do have a very low copay structure. For generics, it's $5 copay, and for brand names, it's a $20 copay. But for some of those really spendy brand name drugs, $20 is a huge savings for folks. And maybe it could be somebody who is waiting to get into the Medicare Part D plan, or maybe they didn't realize that they needed to be in and they're waiting until open enrollment to get in, or whatever their circumstances might be. Serum is going to be an avenue for folks. Now, they don't cover everything. Obviously, it depends on what medications have been made available to them, but they do have a list of inventory on their website, so you can go and order on the website. You can see what their inventory is, and we really want to see this organization succeed. They're partnering with the Pacific University Pharmacy Program, and they have a non-retail pharmacy in Hillsborough where they're going to verify all the medications and then redistribute. Excuse me for a second. So we just recently got word of Serum, and we've been working with them with a few of our client cases, and it's worked really well. So if you want more information on Serum, please visit their website, or if you want to hear more of our experience with them, we'd be happy to share that with you as well. So we have some questions. We'll stop here and take some questions, I think. Okay, for opdp.org, do I need one membership card per family? It's by individual. So you would sign up each individual in your family and use that individual's card when you go to the pharmacy. How much money does, oh, we already had that one. Yeah, that's one we had before. So I think it's just that one, right?
Yeah.
There was something else about a resource. Let's see if we got that. Is this in every state or only in Oregon? I'm not sure what that one was referring to. The resource item. Maybe about the Medicare Savings Program and the resources. That is specific to Oregon. And not all states have eliminated that resource criteria for eligibility. So Oregon is one of few states that has eliminated the resource. Okay.
I think that might be all the, oh wait, here's another one.
Okay, do needy meds or Serum handle diabetic test strips? I don't know the answer to that. On the serum.org/inventory, you might be able to find out, or by calling their 800 number, they would be able to tell you what is available. Certainly that would be something I would think that is in abundance, that is unused, that they could redistribute. So if they're not doing it now, maybe suggest that that is a need in the community, and I'm sure that they would work on that because they've been very responsive to our input. We've had them attend our statewide conference calls by telephone, and they've provided some excellent information. So if you have a network that you would like them to provide more information, Amy Chen is the contact person, and she has just been very accommodating for all of us.
Awesome. Thank you.
All right. So just to wrap up a little bit, Cynthia, did you have anything else you wanted to add before we go on to Sheba?
Nope, that's pretty good. Pretty darn good.
Okay, good. So just a little bit about the Sheba program. We are part of a national SHIP organization, the State Health Insurance Information Program. And in Oregon, Washington, and Idaho, it's called Sheba. Some other areas have different names, but we're all part of this national SHIP program. And we get our funding now from the Administration on Community Living, and we get additional funding from the Division of Financial Regulation, which we're slowly going to be moving out of, and I think starting this month, we're part of the Oregon Health Insurance Marketplace fully. We've been in transition, so we're going to still be under the Department of Consumer and Business Services umbrella, but we're co-located and working much more closely with the Oregon Health Insurance Marketplace. And so we're able to help people who are transitioning off of MAGI OHP or qualified health plans to Medicare. And that can sometimes be a pretty bumpy road. And so we really want to have as much visibility in those circumstances to help folks smooth out that transition from pre-Medicare insurance options to their Medicare insurance options, because we don't want to lose people along the way and not have them get good choice counseling, because their timelines are very critical when they first come on to Medicare. They have certain timelines where they can make choices that may not be available to them later on down the road. So getting them when they're first transitioning from pre-Medicare to Medicare age or Medicare through disability is going to be critical.
Just a point of clarification for some of you, the name change and the kind of program shuffle that's been happening at DCBS, the Department of Consumer and Business Services. The Division of Financial Regulation, you may have been aware of the consumer advocates at the Oregon Insurance Division. So Division of Financial Regulation includes those consumer advocates and some additional folks from other parts of DCBS. So Division of Financial Regulation is a pretty obscure name, but it's the Insurance Division, the Oregon Insurance Division, or part of it, and those real important consumer advocates that you may have used in the past.
Right. It's the Insurance Division and the DFCS, the Division of Financial...
Finance and Corporate.
What is it?
Division of Finance and Corporate Security?
Yeah, Division of Finance and Corporate Security merged, and now we're the Division of Financial Regulation. So probably TMI. You don't need to know all that stuff. So what does SHIBA do? So we have 17 sponsors in 30 different counties. We're missing just a few out of the 36. I think only we're missing 3 or 4 counties. And we have about 250 to 280 counselors that have taken our training program, and we have certified them as Medicare subject matter experts. And so we are blessed to have all of these folks that are volunteering their time in their community with their peers to help folks understand the complexity and the best analysis of what their Medicare, how to optimize their Medicare benefits. And so we do a lot of education and outreach. We provide Medicare 101 classes on a regular basis. Cynthia and I are going to be out in Eastern Oregon for 2 weeks in August, and we'll be hitting every library that we can find in that 2-week period. I think we have 20 presentations in 9 days. Wow. So it's going to be a whirlwind, but you know, the folks that come and listen to our presentations really appreciate getting that just a little bit tip of the iceberg so that they know that they need to get more information to make informed decisions. We also assist with fraud prevention and reporting. So anytime we hear something that doesn't seem right, we're going to, throw up a red flag and say, well, gee, it might just be an error, but maybe it's just the tip of the iceberg and we really need to pursue it more. So we're constantly helping folks to protect their identity. Oregon is the 3rd highest in identity theft nationally. Florida is number 1, Washington State is number 2, and Oregon is number 3. So the very first thing we tell folks is, please don't carry your Medicare card in your wallet, because what does it have on it? It has your name and your Social Security number. And if anything was ripe for identity theft, if your wallet or your purse is stolen, That's going to be the keys to your identity. So we're always, letting folks know this important information. Now, just a tidbit, Medicare is going to stop using Social Security numbers on Medicare cards in 2019. So stay tuned for that. If you're talking with folks in your networks, make sure that addresses are correct with Social Security. Nobody gets mail checks anymore. They all get electronic funds transfer, and people are transient. So in order to have that transition to a non-Social Security number on Medicare cards, Social Security is going to have to mail something to them. So it's very important that they have their address of record accurate with Social Security. In addition to the SHIBA program, there are benefit enrollment centers. Washington County is a benefits enrollment center, and you have on your slides their contact information. There may be other counseling opportunities in other counties, like options counselors through APD, or of course the ADRC program also offers some of those benefits. We have the ADRC website, and we want to make sure that folks are aware of how to find some of these resources. So we've put a list of the keyword searches so that you can find everything we've talked about here today. I did do a few of them last week, and I noticed that some of the ones that I was looking for were pretty far down in the list. So just because you've put in LIS, you may get a lot back. You just have to kind of look if you are looking for SHIBA or if you're looking for something specific about LIS. So just so you know, not to give up the ghost if you don't find it exactly on the first try. So here's that beautiful glossy half sheet for the Oregon Medicare Savings Connect with their phone number. And there are some different pictures that are available to target certain communities. So if you are working with tribal members, we have some tribal member pictures on there. We also have other pictures available. But it's a handy little reference because now it shows on the second page what the resource limits are if you're applying for just prescription drug help, or if you may be eligible for having the Part B Medicare Savings Program benefits. There are no resource limits, but it does give the income limits. So nice little tool there to help with, just showing folks, is your income at or below this amount? And then they can tell you, and then you can refer them to the proper entity.
I believe that was one of the attachments besides the PowerPoint that we sent them, right?
Yeah, it was. Here's an eye chart, but it is a list of all of the counties where SHIBA has a presence, and whether or not you go to the SHIBA central office, like in Baker County. We do not have a SHIBA presence there, but if you do the 800 number and you put in a Baker County zip code, then it's going to route you to the state office, and we will support the folks that are in Baker County through the state office. So that's a nice little reference tool if you need to refer someone to their local office. And then this is another way to look at, and that says 2015, darn it. I missed that. There's so many things to...
So fix your copy out there.
It should be 2016. Yes.
And this was another one that we sent you as an extra handout, so make sure you fix your handout.
The amounts are correct. I just didn't catch it on the title. I apologize. So this is called the house, and some people like looking at it from the bottom up as their amount out of pocket is accumulating. Some people like the chart that we reviewed earlier that was in color going from left to right. So it's just personal preference on how you want to use these tools to your best advantage. And I think that's what we've got, and we've only got about 5 minutes left, so we'll see if there's any other questions. Or Cynthia, do you have anything you would like to add?
No, I thought it was great.
Well, good.
Good job, Donna.
I was really stressing this, and I wanted to have Cynthia on the phone with me because two heads are always better than one, and she's my other half of my brain. So
yeah, so we want to definitely thank Cynthia for joining us from home today. That was really nice of you.
Absolutely.
And I'm not seeing any more questions. This was very thorough. Ryan, did you have anything you wanted to add at all?
I don't have any additions, but I wanted to say thank you, Donna. Great job.
Good.
Yeah,
Very
yeah,
good.
Thanks to everyone who attended, too.
Yeah, thanks to everybody. And this PowerPoint is amazing, and we will make sure that it gets posted with the actual recording of the webinar. So it and the handouts will be up on the website by next week under the webinar sections where we post them. So we'll give just another minute or two. Somebody says, best webinar ever. Thank you.
Nice.
Awesome. Thank you. I think that was Liz. Thanks, guys. Any other questions? We'll hang on for a minute or so, but it looks like that's maybe it. So we really appreciate you guys being here. I want to make sure that y'all know that I will send out an evaluation link here in the next hour or so to each and every one of you. Please fill that out. Next month, on the second Wednesday of August, we will have a disability etiquette and ADA overview for ADRC partners. So I'm looking forward to that one too. We're getting some great folks in here to talk with us about that. So again, thanks very much. We've recorded it. I'm not seeing any questions, so I think we're going to go ahead and close down the webinar. Thanks again for being here. We really appreciate Donna and Cynthia. Thanks so much. And watch for that evaluation and let us know if there's anything else we can do to help you out. Thanks, everybody. Have a great afternoon.
Thank you for attending. Bye-bye.